Hi, I'm Dr. James Johnson, also known as the Floater Doctor. I'm an ophthalmologist located in the Dallas-Fort Worth area, and my practice is exclusive to the treatment and management of bothersome eye floaters, which makes my practice kind of unusual. So I've been doing this for about 19 years. I'm primarily a laser guy. I have some other options available. And very often people are searching for information, why do I have floaters? What caused them? A very common cause of floaters in my older age group patients, and when I say older, over than 50 or so, is something that's called a posterior vitreous detachment, or PVD for short. It is very common. We're talking about 25% of 60-year-olds, 60% of 80-year-olds, and it is a cause, an explanation for sudden onset. I was minding my own business, and all of a sudden I had this thing happen. And it is a common cause for these sudden onset of eye floaters. What are the eye floaters? What are the symptoms? Moving shadows, moving webs, cobwebs, moving clouds. The unifying feature is movement, right? There's a lot of things that can cause blurred vision or dissatisfaction with vision, but the key is when you move your head or move your eyes, there's some sort of movement or shifting of clouds or strands or something that's new and different. And it is an anatomical shift of a membrane, I'll describe in just a moment, and it is generally pretty common, 25% of 60-year-olds, 60% of 80-year-olds, like I said, and not considered to be an eye health problem. That's not to say that there's no risk, but let me first describe what's happening. So we have a couple of views of the eye, looking straight at the eye. We have a virtual cross-section of the eye, and then we have my view, an ophthalmologist's view, looking into the back of the eye. There is two fluid spaces in the eye. There's a fluid space up front, which is filled with something that's called the aqueous. It's a clear, watery fluid. It's involved with the eye pressure management. We're not going to talk about that. We're going to talk about this space right here. This is the vitreous, sometimes referred to as gel. An archaic term is humor, as in a fluid, some component. The vitreous is not technically a gel. It's considered a fluid. Not technically a gel, but it's gel-like. Maybe more accurately, the chemist might call it a viscoelastic fluid. Not quite a gel, not quite a free-flowing liquid like water, but a bit more viscous. And that does change with age. In a younger person, let's say in their teens or 20s or 30s, it will be a bit thicker and more gel-like. A natural aging change and phenomenon is for it to become more liquefied. In that vitreous space, there are no cells, there are no tissues, there's no vasculature, there's no nerves, there's no hormonal activity or immune activity. It's a pretty bland and boring space. And most of ophthalmology generally is not all that interested in the vitreous. There's ways to monetize treatment of the front of the eye. There's ways to monetize the treatment of the back of the eye, not so much with the vitreous. So the typical standard of care and the typical experience for the patient is sudden onset, moving shadows, moving disturbances. They go to the doctor. The doctor hopefully will dilate, preferably will dilate to get a better look in there. Take a look around, look at the retina primarily and say, well, the good news is your retina's okay. Okay, great, but what about the floaters? And that's when they already have their hand on the door and ready to move on to their next patient. Not particularly interested in the floaters themselves. So what's happening here? We have the gel. The gel has a baggy or a sac-like containment to it, like this. This would be the normal youthful configuration of the vitreous. That membrane is transparent. We don't see it. You don't see it. It's just part of the vitreous. Nobody cares about it. A PVD is when the back part, the posterior part of that vitreous separates from the back of the eye. And when it's completed, it will generally remain attached out here, what's called the vitreous base, and generally anterior as well. But the back half or so of that vitreous will completely separate. That event, which can occur either immediately or over the course of days or weeks, and in some instances, years, it's possible. But most of them will occur fairly quickly within immediately days or weeks. When it's completed, you have a new normal for you, a new normal situation, a new anatomical configuration. Now, it's while that is separating, while that membrane is peeling away, that's where you have your potential problems. It's as that's peeling away, that's where you get your traction, okay? It's like using painter's tape on the wall, right? You put the painter's tape up, you're gonna paint the trim around the door, it all looks great, and you go to peel that tape away and you're like, do I rip it? Do I do it slowly? I don't know. But if you do it as you're peeling it away, that's when you're at greatest risk for tearing the paint off the wall. That's also when you're at the greatest risk of pulling the retina off or creating a hole or a tear. So a few statistics, these seem high because, I don't know, they just seem high, but the numbers are the risk of a retinal tear in a symptomatic, that is, new onset moving shadows, flashes, and floaters, of a symptomatic posterior vitreous detachment, the risk of a retinal tear is 8 to 15%. The risk is for retinal detachment is about 4%, so much lower. So it's possible to have a small tear that doesn't necessarily progress to a retinal detachment. And of that 4%, especially if the vitreous hasn't completely separated and you're still having symptoms of flashes, which is that internal traction, which is that vitreous which has not completely separated, that risk goes up another 2 to 5% in the ensuing 6 weeks. The risk of a retinal detachment or retinal tear related to the symptoms, if you have just flashes alone, the risk is about 5%. If you have flashes and floaters, that risk is 20%. Again, I think that's high. If you're experiencing hemorrhage, how would you know if you have a hemorrhage? If you have gazillions of small little black dots everywhere, that would be individual red blood cells. That risk might be as high as 70%. As that vitreous is separating, it's possible to breach a small superficial blood vessel, but it is also possible to tear the retina and also tear one of those blood vessels as well. The presence of a hemorrhage is a bit more concerning, and you have to really, really look to rule out a retinal tear. Other associated risks, if you're a very highly myopic person, and highly myopic will say greater than -6 diopters, you'll tend to get retinal detachments at an earlier age, maybe 10 years earlier. And then I've noticed that when these high myopes come to me with symptomatic floaters, like that membrane just is also thicker. Like their floaters it's not just that they had the posterior vitreous detachment, but it's thicker. It's like wax paper rather than a transparent food wrap membrane. It's more like wax paper. So they tend to have PVDs and floaters at an earlier age, and the floaters just tend to be worse and more symptomatic. Sorry to say. Other things like events, like people who've had a cataract surgery. I don't know if it's the manipulation of the eye, the fluid fluctuations tends to tip those scales a little bit earlier. And I've had many, many people who come to my practice who had uneventful, uncomplicated cataract surgery and had the onset of a PVD within weeks or so later. And then there's other rarer considerations when people have epiretinal membranes or instances where they tend to have more traction or more attachment of the vitreous membrane to the retina. They'll tend to have more likely to have retinal tears or retinal detachments. So a PVD is not without its risk. But here's the good news. Let's say you're a highly myopic person and you've been told by a few doctors you are at greater risk of having a retinal hole and tear. So you go about your entire life with this risk cloud, dark cloud following you around, and you're like, oh my gosh, they told me to limit activities. Like I could be anywhere in the world and I could have this retinal tear and detachment. Statistically, that's true, but here's what they don't tell you. Once that vitreous has separated completely, your risk of retinal hole, tear, and detachment should go to nearly zero. If that membrane has peeled off the back wall there's nothing to pull and tug on the retina anymore. And you may have floaters, you may have symptomatic floaters, that's another issue to address, but the risk of vision-threatening loss of vision, that risk goes down to nearly zero. So that's kind of a silver lining, I suppose, of having a completed posterior vitreous detachment. So how do you know if it's complete? Well, that is a transparent membrane in a dark space, and it is difficult to look in the eye, even with a widely dilated pupil. I think it's very, very difficult to tell if it's completed. I think one of the best tells, one of the best ways to do that is if you had flashes of light, and those flashes of light have subsided over time, and you no longer are having flashes of light. And by the way, the flashes of light are usually associated with some ebb and flow and movement and turbulence of that vitreous fluid. That usually is with eye or head movements. You move your eye, you move your head, you get a little flash of light. When those have subsided, you're not seeing them anymore, it's fair to say that that risk is gone. Like, the vitreous has detached and everything has moved into this new normal. Now, what's the typical experience? Again, patient has minding their own business. Maybe they've had cataract surgery. Maybe they're high myope. Maybe not. They're in their 50s, 60s, 70s, and all of a sudden, out of nowhere, they get some flashes of light. They get some new cobweb, cloud movement or something in their vision. Move their eyes, move their head, it moves around this way. Move their eyes this way, it moves this way. Those are moving shadows. The vast, vast majority of that will be membrane. It will be Weiss rings. It will be clouds that form. And so they get on the internet and they poke around a little bit, and your ChatGPT or AI assistant, Gemini now, or just Google search, says it could be a retinal hole tear and detachment. You better get it checked out. I agree. I think that's good standard of care. So you get in and you see your optometrist, and oftentimes they don't dilate. They'll use wide angle photography. I don't think it's the same thing. I think you should have a dilated examination, but get in to see somebody. They'll dilate, they'll take a look around there, and mostly they're looking at the retina. Because again, we need to rule out the vision-threatening, risky condition, retinal hole tear and detachment. And once they've ruled that out, they might say, okay, it all looks good now. Again, you have the floaters. It all looks good now, but we should see you back in 4 to 6 weeks to try to catch that other 2 to 5% that might have a continued detachment. And if they're back in 6 weeks, the flashes have subsided, the retina looks good, they probably don't need to see them again, back in a year or whatever. That's how most people experience. Then the patient says, well, great, I don't have a vision-threatening detachment, but what about the floaters? And that's when you start to see the backpedaling. Well, the floaters will disappear, they'll drop out of the way, your brain will get used to it, there's really nothing to do for it. Or if they have a more complete conversation, well, there is this surgical procedure of vitrectomy, but you don't want to have that done because that's just risky. And so that's that person will go home and they're like, okay, well, 6 weeks, I'll go back, get it checked out again. And 6 weeks later, there's no change. The floaters are about the same. The doctor takes a look in there and says, well, the good news is you're kind of out of that window of time where it's a risk, off you go. The vast, vast, vast majority of how people have their floaters managed is just as I described. Examination, follow-up, reassurance, told nothing can be done, or at least the doctor mentioned a surgical procedure, the vitrectomy, but greatly discouraged it. For those of you that don't know, a vitrectomy is an invasive surgical procedure. Incisions are made in the peripheral part of the retina. Generally, all of the vitreous, all of the proteins, all of the antioxidants, all of the membranes, everything is removed and replaced with saline. It sounds pretty dramatic. It kind of is. There's a very high rate of cataract formation. That's clouding of the lens. That's very, very, very common, which might obligate to a second procedure. And I'm not against the vitrectomy. Occasionally I will recommend it. Either primarily, I'll take a look in someone's eye and say, yeah, the laser really isn't indicated here. You're best getting a vitrectomy. Or it might be after a treatment or two of the laser and we just can't get traction. We can't get them out of that 10 or 20, 30% improved range. Maybe the vitrectomy is the way to go. The doctors that have the skills and the experience to perform a vitrectomy generally don't consider floaters to be bad enough or enough pathology to justify this procedure. They do vitrectomies, but they usually do them as part of a more complex procedure like retinal detachment repair, membrane peels, things like that. So they might mention it, but generally kind of discourage it. The mainstay of my practice is treating, especially those over the age of 50 or so, with really bad floaters. Very commonly due to posterior vitreous detachments, but it's also possible to have really bad floaters without a PVD. So the presence or absence of a PVD is not a prerequisite for treatment in my practice. It's just a very common explanation as to why you have really, really bad floaters. I am located in the Dallas-Fort Worth area. I get that it's inconvenient. In fact, I just treated a patient this morning, a young guy who's actually a candidate for treatment, from Korea. People will travel ridiculously long distances to get their floaters treated. I understand it's inconvenient. But I will say that experience really, really, really matters in this regard. There's a lot of people offering the treatment of floaters. They say, I have a laser, I can treat floaters. Do your due diligence and caveat emptor, buyer beware. Make sure you find someone that has a lot of experience, because it's not just point and shoot. It's not automated. It's every shot of the laser is a new set of decisions. So make sure you find somebody who has a lot of experience in that regard.